evening, everybody. Glad to see you all in the Sarasota region. I'm so happy to be here. This is a Compass MS Care program. My name is Stuart Schlossman. I'm president and founder of MS Views and News. This started a long time ago. We won't get into that tonight. Tonight's program, though, is supported by Sandoz, TG Therapeutics, and Genentech. Let's give them a round of applause. Thank you. We also had exhibitors here today in case you did not get a chance to see them. We had Alexion, we had EMD Serono, Novartis, Sandoz, and TG Therapeutics. So I want to thank them all for being here and helping to support today's program. So we are going to get started. Dr. Negroski is here. You all know who he is. If you don't know who he is, maybe you should know who he is. I'll let him explain who he is. How's that? And Dr. Negroski is going to speak with you about new MS treatment options, including biosimilars, a little bit on biomarkers, access to care, and a few other things, all right? So let's welcome Dr. Negroski, and I'll give him the mic. Thank you.
Thank you. Thank you, Stu. So I want to thank everyone that drove here, and I want to thank the people at home watching it on the web. So I think we're going to have a really interesting presentation. So as Stu was saying, and thank you for the invitation, Stuart, for me to give this lecture. And so the lecture was new MS treatment options, including biosimilars and telemedicine. So I thought I would kind of change the title a little bit and entitle this "Look into the Future of MS," because I've been around the world of MS for many, many years. I came to Sarasota from Cleveland Clinic back in 1985. So I've established a practice here in Sarasota, which kind of morphed into an MS practice. So as a result, I've seen MS from both sides before we had disease-modifying therapy. And now I see MS now, so I would like to kind of take us through a journey with MS and hit all the topics that Stuart was telling us about. So where do we begin? So years ago, probably in the 50s and 60s, there was a debate in the neurology community whether to tell a patient or a person that has MS. Should you tell them they have MS or should you not tell them? Because there's no treatment for it at the time. So that morphed into should you treat or not treat when there was only a handful of drugs? And more importantly, who should you treat? So back then, when the drugs first came out, the first drug came out in 1993 to change the disease course. We tended to treat patients with long-standing MS and not newly diagnosed patients. So we know that now treating patients early in the disease course kind of shifts the trajectory of the disease, and I'll get into some of the prognostic factors with that. So when do you begin treatment? And more importantly now is how to follow your response to treatment. Do you follow side effects? Do you follow if you have relapses? Do you follow the MRIs? Do you follow biomarkers? So the treatment is getting into this condition called personalized medicine. It's a medical mode that separates people into different groups in order to tailor decisions, interventions, and drug based on predicted responses. So that's what I'm going to kind of get into, how to kind of personalize your journey with MS. So people, when I first talk to people that come in the office and make the diagnosis of MS, they want to know what type of MS do I have. So let me kind of back up a little bit. MS is MS, right? Types were invented years ago to put people in certain categories for research to look at drugs. And they group patients into those with relapsing types of MS, those with progressive types of MS, and so they can enroll similar patients in clinical trials. So there's different patterns. So for me to answer that question for patients, what type of MS do you you have to follow a patient over time, because that's how you diagnose patients with different types. So the types are actually kind of going astray a little bit. And we're kind of looking at how we classify MS. MS is MS. Sometimes it's more progressive, sometimes it's more relapsing, and we'll get into that. So this is a Venn diagram that I like. There's this condition called prodromal MS. There was a study in Canada where they looked at patients with MS, but they looked at their charts way before they were diagnosed to see what their hospital visits were, what medications, how many times they saw a doctor. And in retrospect, patients that were eventually diagnosed with MS had more patient visits, more health encounters before they were actually diagnosed, which kind of makes sense. So that's this prodromal MS. They have something going on. They can't put their finger on it. Their healthcare provider can't put their finger on it. So prodromal MS. Then you have what's called radiologically isolated syndrome. That's when you do an MRI on a patient, and for whatever reason, typically it's headaches or whatever, and all of a sudden the radiologist comes back with a report saying that they have the person has little spots in their brain, which could be MS. They come to my office, you examine them, clean as a whistle, take a history, no history of MS symptoms whatsoever, but their MRI brain definitely looks like MS. So there is a debate now what to do with those patients. Do you treat or not treat? And so there are studies going out several years to try to follow those patients. Some patients are treated, some are not, to see what's the best approach. The flip side of the coin is clinically isolated syndrome. That means where you have a typical symptom of MS, like optic neuritis, inflammation of the spinal cord, and you bring the patient in. They have no history of prior events, but they have their first attack of MS, clinically isolated. We used to follow those patients along, but now we know that if you do a brain MRI or a spinal MRI and there's lesions there, those patients are at high risk for developing a second attack. And there's information that those patients would benefit from going on disease-modifying therapy to lengthen or to make it longer before they take their second attack. So it extends their symptoms, especially if they're at high risk based on the MRI. Then you have the typical relapse and remitting category and secondary progressive. So those two are kind of morphing together. Secondary progressive is further divided if it's active or inactive. Activity is by definition a relapse or MRI activity, right? So you can have secondary progressive MS that's inactive. You do an MRI every year, it's stable, there's nothing going on, patient doesn't have a relapse, but they may have progression of their disability. So it's based on activity, active or inactive. And then a separate form of MS is primary progressive MS. It's a little bit different. Those are the people that have their first attack and they never get better. They keep on getting worse as time goes on. So we think that it's a little different because there's more men than women in primary progressive MS. It's just the opposite in relapsing remitting MS. Primary progressive MS patients have more spinal cord involvement than brain involvement. So that's kind of a separate type of patient group. So as I mentioned, MS is a continuum. That Venn diagram that I showed you there, those little things overlap. So that overlapping area is expanding. So the reason it's expanding is because MS used to be thought as an inflammatory disease early on, and then later on a more degenerative disease that explains slow progression of disability. But now we think that both of those go on at the same time. Early on, you have a lot of inflammation. That leads to activity, relapses and MRI activity, right? Inflammation, new spots, new enhancing lesions in the brain. And then you have what's called neurodegeneration, which means there's another mechanism going on that tends to cause worsening of disability. And we'll get into some of the biomarkers and MRI markers of neurodegeneration. So the new term that is coming about is PIRA. Anyone hear of PIRA, P-I-R-A? PIRA MS? It's progression independent of relapse activity. So patients will come into the office. You do an MRI every year. Year after year, the number of lesions look the same. They're not having relapses, but their disability, it takes longer to walk in the grocery store to do all the groceries you should. Whereas 2 years ago, you can make one trip. Now you have to make 2 trips. So very subtle changes. That's why it's important for care partners to come into the office with the patient, because they can pick up some very subtle changes of worsening of disability. Whereas the patient may think everything is fine, but if you ask them what they did 2 years ago or 2 months ago, maybe it's not the same. So PIRA, you're going to hear a lot about that in the future. So you can see that things have kind of morphed more into a kind of buckets, more to a swimming pool of MS, right? So prognostic factors, I'm going to spend some time because I think this is important for patients to kind of understand. So the other thing that keeps me awake at night, truly, and I worry about my patients, but I worry about the patients with more poorer prognostic category. And I'll go over this because you gotta understand this. So this personalized medicine is based on trends. And so through the years, we kind of know what patients we should be concerned about early on and which patients should disturb our sleep patterns and be worried about. So to the left is better prognosis, to the right is poor prognosis. So better prognosis, I'll go through these in detail. Monofocal onset. Your first symptom is like one symptom. It's not like 2 or 3 symptoms at once, like optic neuritis and paralysis or whatever. It's just like optic neuritis. Minimal cortical pathology. The cortex is the gray matter, and then everyone understands the gray matter has to do with cognition, cognitive abilities, things like that. So early onset of cognitive issues is a poor prognosis. Good prognosis is minimal cortical pathology. Onset with optic neuritis and sensory symptoms. That's a good thing. There's different forms of optic neuritis. Optic neuritis is scary when your eye nerve is inflamed, but in general, it's a good prognosis because majority of the time, patients with optic neuritis improves. So if the onset is more motor, weakness, balance, cerebellum, or bowel and bladder symptoms right at the onset, that's a worrisome prognosis. Low relapse rate in the first 2 to 5 years versus a high relapse rate. That kind of makes sense. High degree of remission. This is a relapsing remitting disease. So if a patient has a clinical attack and they have complete resolution of their initial symptom, that's a good thing. But if their symptoms improve maybe 60%, 70%, but they linger, that's not as good. Mild relapse, obviously, versus a severe relapse. Those relapses that you have initially that put you in the hospital that you need steroids, that's a severe relapse. Low disability at 5 years versus increasing disability at 5 years. That kind of makes sense. Low lesion load on MRI when you're first diagnosed. If you don't have a lot of scars, of MS scars in your brain, that's a good thing. If you have a lot of them, that's a bad thing. Early treatment, as I mentioned, is a good thing early on. Delaying treatment, you never kind of catch up a little bit. That's a bad prognostic sign. So not only do you have to diagnose patients, but in order for me to kind of judge their response, it takes a while, their risk of disability over a period of time. So from day one, it's very difficult for me to tell what's going to happen to the patient long term. After a year or two, you kind of figure out what's going on with the patient, and you're better able to personalize their treatment. So personalized medicine has to do with picking the right drugs. All drugs are not created equal, and we'll get into that. So treatment landscape has changed dramatically. When I came here in '85, there was no treatment for MS. Actually, when I did my training, there was no fellowship, which is a specialty of MS, because neurologists didn't want to go into multiple sclerosis because there's no treatment for it. And now it's just the opposite. I can't tell you the advances that we have made in treating MS patients as opposed to other neurological diseases. MS has come a tremendous way. Thank God for research on certain drugs and the way we approach patients. So over the past 12 years, 19 new and 5 emerging therapies are available. The first 18 years, there was only 6 treatments. Now there's like 23. So we used to classify the drugs by how it was administered. So some drugs were administered under the skin, called subcutaneous injections. Some drugs were pills. Some drugs were injections in the muscle. And some drugs were infusion through the vein. So we don't classify drugs necessarily by how they're administered. We used to when we didn't have that many drugs. But more importantly, now that we have options, we classify them by the way they work on the immune system. And I'm going to spend some time on the various drugs and how they work on the immune system. So we classify them by certain categories. Immune modulation. You modulate the immune system. So the immune system is made up of various cells the innate and you're born with two immune systems. One is the innate immune system from scratch, has to do with skin and protection and cells under the skin. So when a baby is born, the baby is protected from the environment. The second immune system is called the adaptive immune system. That's learned through various mechanisms, and it educates the immune cells for protection. And the cells that we're talking about are T and B cells. So T and B cells are part of the white blood cells. So when you go to get a blood count, you'll see WBCs, white blood cells, and then you'll see all these Greek terms, lymphocytes, eosinophils, basophils, all that stuff. But it's the lymphocytes that are the players and actors and actresses in MS. So those T and B cells are further divided into subtypes of T and B cells. So as the research progresses, drugs are kind of marketed and targeting certain specific T and B cells that are the players in MS. So you can classify drugs by modulating these cells, the immune system. You can remove the cells from the circulation and park them in a garage, and they're still alive, but they're out of the system, and they can get into the brain and cause problems. You can reconstitute your immune system. You can get rid of the MS cells, and maybe your own bone marrow will grow non-MS cells. You can limit how they migrate, circulate around, and so they don't migrate into your brain, and then you can kill them. It's called lymphocyte depletion. So there's various ways these drugs work. So the next few slides they look busy, but don't get depressed when you see these slides. I know you guys are eating, so there won't be any kind of, if you want to eat some more during these boring slides, you can do that, so I won't feel upset. So let's look at one of these categories, immune modulation. These were the class of drugs that first came out for the most part. You see beta-seron came out in 1993, and then there's other kind of interferons, and then there are Copaxone and some generic forms of that. And then there's some pills called teriflunomide or Aubagio, came out in 2012. And then we had it's called the fumarates, Vumerity, Tecfidera, Baffertam. So those are another class of drugs. And you can see when those drugs were kind of approved and how the dose and how often they're given. So this is a busy slide, but it just puts these drugs in certain mechanisms of action. Now, what about sequestering the immune cells? So these are this class of drug sequesters the immune cells. So the immune cells are circulating around these T cells that are players in MS. They're circulating around the system. So what if you park them in the garage or a hotel? And I like the Hotel California thing. You check in and you don't check out. So these cells are not dead, but they check into the lymph nodes, and if they sit there, they can't get into the brain. So Gilenia mason Zeposia ponvori. What if these immune cells that are circulating in your system, you inhibit their migration into the brain? The brain is separated from the bloodstream by a barrier, it's like a sieve. And sometimes the sieve gets open, and sometimes the sieve can get closed. When it's closed, this drug called Tysabri or natalizumab closes that sieve, so the immune cells stay in the bloodstream for the most part. That's given IV. So what about depleting the cells? So there are treatments to deplete cells, Ocrevus, Kesimpta. Those are, Kesimpta is administered sub-Q every month. Ocrevus is an IV every 6 months. The new player on the market is Briumvi, and that was FDA approved in 2023. It works a little bit different than the first two because there's a little glucose deal going on, which makes it attach to the MS, the lymphocyte, a little bit. It gets more sticky, it attaches, and the dose is a little bit less, and it takes less. It only takes about an hour to be infused instead of several hours. So that was the new player on the market there. The cells that change, these classes of drug reconstitute the immune system. One is called Mavenclad. It came out in 2019. An IV form came out in 2014. So these cells are both, they deplete the lymphocytes. The first 3 drugs kills the lymphocytes by lysing them. So they kind of explode. It's like a cherry tomato. If you want to get rid of a cherry tomato, you can either squeeze it and all the juices run out. And when the juices run out, it causes inflammation in the system called cytokine release. So you have to be pre-medicated sometimes with some of these drugs that lyse cells. The Mavenclad will kill the tomato by snipping the vine. It's called apoptosis. That's a medical term. It doesn't destroy it. It just, they wither at the vine, so you don't have to pre-medicate. So the new people on the block are called BTK inhibitors, butyl tyrosine kinase inhibitors. So I just want you to know that there is a exam at the end. We'll pass out the little cards with the pencils, and you have to fill in the little dots, okay? And in order to exit the building, you have to score at least 90%, okay? So pay attention. What? Spelling doesn't count. So Buten was a pediatrician in 1959, I think, and there was an 8-year-old little girl that they found had kind of an abnormal immune system. The globulin level was non-existent. Globulin has to do with the immune system. So they kind of found these inhibitors, and they named the class of drug Buten for the pediatrician and their patient in 1950s. Isn't that amazing? It's kind of interesting. So these are, what they do is they look at a different group of immune cells instead of the T and B cells. For the most part, there's macrophages and microglia. They're like the garbage men of the brain. They go in and kind of clean up things. They clean up debris and stuff like that, and sometimes they don't do a good job, sometimes they do a good job. So we try to kind of influence the way they work in the brain. So this drug works at the periphery, and it also works in the brain. So these are the drugs. There's like 1, 2, 3, 4, 5, at least 5. The first one that was supposed to be first to market failed. So Merck decided not to proceed with marketing it. So when this drug was looked at in the clinical trial, you compare it against another active MS treatment. And this drug was compared against Aubagio. Aubagio has been around for a long time. But when they looked at the data, the first cutoff point, the Aubagio group and this group did the same. But the Aubagio group actually did better than prior Aubagio groups. So that group was artificially high, and so, but statistics are what it's worth. They're relooking at the data, but that was a setback. There's been some issues with liver enzyme abnormalities and a case of liver failure or two that needed a liver transplant. So the FDA is kind of looking at this drug class in a different way, but next slide. So there's some interesting things I have some patients ask me about what's kind of out there, and there's a antihistamine class of drug called clenmastine. Anyone here knows about that? There was a study at UC San Francisco that looked at myelin content, which is the insulation in your brain, and with a special type of MRI, and they published this in May of last year, 2023, and it improved myelin content of the water, and it's just like it's an antihistamine. Metformin is a diabetes oral drug, and it also acts not only in diabetics, but it acts on oligodendrocytes that kind of myelinate the nervous system. And then the big thing is stem cell treatments. So let's back up about stem cells. So stem cells come from different places. The most common stem cell is taken from your own body and in your blood. It's called hematopoietic stem cells. That's the most common form of stem cell therapy. Mesenchymal stem cells come from the bone marrow as well as the fat in the skin. They're harvested. Fat or cells come from nervous tissue. Human embryonic cells come from donated fetuses. And induced stem cells are kind of manufactured by a certain way. The trouble with the last two is that, or maybe the last three, some of those patients develop tumors. So not all stem cells are created equally, number one. Number two is that stem cell treatments may cause risk in terms of development of tumors. So you really got to know what you're doing. So the National MS Society has come out with recommendations, and they recommend that patients that want stem cells should go to an accredited center. And it's called Foundation for the Accreditation of Cellular Therapy. They have to be accredited or in a clinical trial. But you got to watch, there's this term stem cell tourism. So there are clinics popping up in not only the United States, but around the world that really don't follow the accredited kind of stem cell thing. So you really have to be careful. So I would encourage you to look at the National MS Society website for their recommendations. There's some interesting thing on TMS, transcranial magnetic stimulation. That's where you put a magnetic waves, and then it goes through a coil and it turns into electrical impulse, which influences the flow of electrical impulses in your body, in your brain and other places. So there's a lot of research looking at not so much treating MS pathology, but MS symptoms, spasticity, cognition, pain, all kinds of stuff with TMS. Functional electrical stimulation is to stimulate the nerves that are weak in your arms and legs and things, like pens and things like that. So next slide. So let's kind of change to a hot topic. So in our community, the MS community, aging and MS is becoming a very, very hot topic because the baby boomers years ago, there were a lot of patients that got MS because the patient population pool was pretty high. The baby boomers, there are a lot of them. And those baby boomers have now kind of progressed, and they're in their late 50s, 60s, 70s, and they have MS. So it's difficult to understand what is normal aging and what is progression of MS disability. And when do you treat patients, or when do you stop treating patients? So normal brain loss when you get older is around 0.1 to 0.3% volume loss per year. Okay, normal brain loss. In MS patients, it's 0.7 to 1% per year. So that speaks to this neurodegenerative component, as I talked to you about before. So, what is MS versus aging? So normal aging is also associated with some low-grade inflammation. So as you get older, you're at risk for more infections because your immune system may age. You're at risk for other things. So it's often very difficult to differentiate the two. And I think they go hand in hand. They really do. So as a result, there's growing interest in de-emphasizing the distinctions between relapsing and progressive MS, as I mentioned initially. Those two Venn diagrams are kind of overlapping each other, relapsing and secondary progressive MS. Next slide. So, how do you follow the response to treatment? Years ago, we would just look at relapses, disability, if it's better, worse, and MRIs. That's how clinical trials of MS drugs worked. Next slide. So, what kind of MRI metrics do we use? Well, you can look at number of lesions, but more recently we look at other things. The rate of brain atrophy, if it slows up with certain drugs. What's called a paramagnetic rim, that's a fancy medical term, but remember the macrophages and microglia, the garbage people of the brain. There's special MRIs that will pick up this rim around certain MS plaques, and they're called smoldering plaques. So you can have an MS lesion. You don't know if it's not enhancing, but it's just smoldering away. It's still active. And those plaques have some iron around it, right? That's why a magnetic field you can use an MRI to kind of pick that up, picks up the iron. And it looks like a little rim around plaques. And we think it's those plaques that slowly increase a person's disability over time. So that's why these MRI metrics are really important. The central vein sign is a new kind of phenomenon because some people have plaques, but they don't have MS. They could have small little mini strokes. But if you have a central vein sign, chances are that little white matter lesion on the MRI is from MS and not a little stroke. Next slide. So what about biomarkers? As I mentioned, there's personalized medicine business to try to figure out what the best treatment is. At the time of diagnosis, we used to do spinal taps a lot. back in the 70s and 80s. The pendulum swung when the MRIs came out. And then hardly anyone got spinal taps. Now the pendulum is swinging back the other way. So spinal tap is often abnormal 95% of the time, but you can still have MS about 5% of the time. These other biomarkers, the anti-APQ4, that is for a non-MS disease called neuromyelitis optica. So neuromyelitis optica is very important to diagnose because, in my opinion, it's worse than MS. Patients can get optic neuritis, but their optic neuritis tends not to go away. And they tend to get spinal cord lesions that lead to severe deficits. The treatment of that is completely different for the most part of some of the MS drugs. As a matter of fact, a couple MS drugs make that condition worse. So you really want to make sure that the patient doesn't have that, so you kind of run this biomarker. Another biomarker is MOG, M-O-G. It has to do with the myelin and oligodendrocytes. It's not an MS thing, but it's a milder case of kind of the presentation of MS. It looks like MS, but it's not. Next slide. So how do you monitor if your treatment is good? So obviously, if you have relapses on treatment, assuming that you're taking the drug, some people don't take the drug. That's why I like the care partners to come in. You know, they taking pills or something or shots, and I go, "Are you taking it?" And they go, "Yes." And then their care partners squirming in their chair, rolling their eyes, sighing, trying to give me a special, like a secret code. You know, so you have to take the drugs. The drugs won't work if you don't take them. So I need to know. Monitor for new disease activity. So what's new disease activity? Is it new lesions? So if on a yearly scan, if you have 2 or more new lesions, maybe you got to sit down with the patient and talk about changing the therapy or escalating therapy or changing it. You should have, when you change therapy, you should wait about 6 months and get a new MRI as a new baseline, because you need to know if additional lesions are seen before the 6-month period. So any lesions after the 6th month is on the dime of the new drug. Does that make sense? So you get reset a new baseline MRI when you change therapy. And then do you measure brain volume or not? And then the most important thing is, when I talk to patients, is treat to target. That means I need to know what your target is. I know what my target is. I want to shut the disease down as much as I can. But your target may be, I want the safest drug around. Your target may be, I want the latest and greatest new bright shining object, to be treated with. Your target may mean that I want a really strong drug that may have some serious potential fatal complications, but or I want the kind of the safest drug. So your target may be different than my target. So I need to know what your target is, because the worst thing I can do is force a treatment on you that you really don't like. And typically what happens is that, I'll mention certain treatments, like 2 treatments or whatever, and everyone shakes their head, yes, 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 and then they go out the door. And I've had this happen. The care partner calls me and says, "You know what happened? As soon as they left the office, my wife or partner said, 'I'm not taking that,'" right? But they didn't tell me that. But, it's important. You have to be frank and honest with your with your healthcare provider. Next slide. So what are the other biomarkers? How can we see if a patient's going into that PIRA stage? That's the big thing. So there's this PET signal kind of that may predict later disease progression independent of relapses because it's a marker of this microglia business, because that's a hot topic, microglia, PIRA, microglia. So there are some markers looking at that. Neurofilament light, NFL, not the football stuff, but neurofilament light is a marker of axonal damage. Concussions, traumatic brain injury, Parkinson's, MS, anything that breaks the axons releases certain markers in the bloodstream, and you can pick that up. The other thing for a marker of PIRA is another blood test called GFAP. This won't be on the test, so don't worry about it. So GFAP, marker of PIRA. So it's a blood test. There are some companies out there that are trying to put together, there's probably 20 some markers, and they're trying to put together this algorithm and test patients' blood with these markers and follow them along to see if they are responders to therapy or maybe at increased risk of disease progression. And the jury is still out a little bit, but that's where things are kind of heading. Next slide. So this is 3 sections. That was the first section, okay? So what I'm going to do is kind of switch a little bit. This isn't as long, and I'll take questions at the end if that's okay. So brand, generic, biological, biosimilar drugs. So that's a big thing these days. So let me kind of dissect what each of those terms are, because they're completely different. Okay? A generic versus a biosimilar, they kind of connotate the same thing, but they're not. So biological drugs, such as monoclonal antibodies, those are typically some of the MS drugs that are infusions. They're huge molecules. You can see monoclonal antibody, huge, heavy molecule. It's the weight is 150,000 Dalton, which is a weight of little things. Aspirin is a chemical, 180. Aspirin is a chemical, okay? Insulin, 5,800 Dalton. And then monoclonal antibodies, a biological drug, which is very difficult to make because it's typically grown in cultures. It's typically a biological drug and not a chemical drug. So there's differences between branded drugs and biological drugs. So next slide. So let's talk about chemical and biological drugs. Description. Chemical drugs is what most people think drugs in medicine are. Okay? Chemical drugs. It's a tablet or a capsule that you take by mouth, generally made from chemicals or small molecules. It's chemically combined with some ingredients. And the generic or biosimilar of a chemical drug is called a generic. So let's look at biological drugs. There are gene therapies, proteins, vaccines, monoclonal antibodies. When you see these ads on TV for like Crohn's and psoriasis and MS, they look at this big name, and at the end it says, alatuzumab, MAB at the end. That means monoclonal antibody. If you look at that chemical name, those three things at the end, MAB, means it's a biological drug. It's a complex thing. It's produced in living systems. The manufacturing process is often confidential. Okay, it's very difficult to make. Next slide. So a generic versus a biosimilar. That's the generic is the biosimilar of a biological drug. Biosimilar. So generic is equivalent to the name, the brand name, whose patent expired. Same active ingredients, no significant difference in the rate of absorption, should deliver the same active ingredient concentration in the bloodstream. It's called bioequivalence. And that is around 90 to 110%, according to the U.S. pharmaceutical guidelines. So it should be bioequivalent. Biosimilar are different from generics because it's very complex. They have a high significant research and development cost, and they may be more riskier because of their significant research and the complex nature. Next slide. Biosimilars, same mechanism of action, route of administration, strength, and approved for the same indication. It's not a different indication, the same thing. Okay. The reference manufacturing process is proprietary. Remember, I told you that it's kind of confidential, so they do have to do research to develop the drug. They can't just copy it because it's like paella. You know, there's a lot of stuff in it, and it's kind of hard to copy paella, I think. I don't know. But so it's expected to produce the same clinical result. Next slide. So this is interesting. I learned a lot. Chemical drug development time for like aspirin, chemical drug, 7 to 10 years, $80 million or $800 million. Okay. Generic drugs, 1 to 3 years, 1 to 2 million. So it's really cheap to make generic drugs. Okay. Biological drugs takes 10 to 15 years to develop at a cost of 1.2 to 2.5 billion. So, you know, these biological drugs are very, very time consuming, billions of dollars to develop. Biosimilar drugs take about 8 to 10 years, and they get off the hook. It only is about $100 million to $200 million because of the approval process. Next slide. So this is very complicated, but I just want to draw your attention to a couple things. The original biological pathway is called the 351A pathway, and that's the $2.5 billion pathway to go through that. The one to the right of that is called the FDA 351K pathway. It's a different pathway for biosimilars. And you can see that the pyramids are inverted. That's why it doesn't take as much money. The FDA approved a first biological or biosimilar drug to Tysabri in August of 2023 by Sandoz. So that is a biosimilar to Tysabri. It's called Tyruko. I don't know what that stands for, but it sounds kind of exotic, I think. I don't know. But Tyruko. So it was based on a study called the Antelope Study of about 264 patients, and they looked at the number of new active lesions, and they also looked at other things. But the FDA gave approval to Tyruko by Sandoz August of 2023. Next slide. So the benefits of the pathway, what they did is they changed it from, 3, 5, 6, A to K, because it shaved time and money from the development of a biosimilar drug to a biological agent. Next slide. So this is a study of 62 MS patients, and we're talking about generics now, not biosimilars. 62% or 62 MS patients, 32% did not trust generics and were treated with branded DMT, disease-modifying therapies, because they valued efficacy over price. Okay, about a third of patients. Factors, the line above that, factors that were associated in one study with higher prescription of generics by providers were older providers, general neurologist, that were willing to take risk in multiple domains. That was a kind of a strange study, but now this is a study that just came out actually a short while ago. This is a study on fingolimide where they looked at Gilenya. Gilenya is the branded drug, and fingolimide has various generics, not just one. So this group took branded fingolimod and looked at the USP acceptance criteria. As I mentioned, 90 to 110% should be the active ingredient in the assay. So the branded Gilenya was 94.1%. The generic batches were, one was 76.8. It was way lower than 90%. Which was recommended. Two other generics were okay. They were 92.4 and 102.1. And then they followed it up with another study that was just published in 2000, just recently, a few weeks ago, that showed the same difference within the same generic batch, but a different bottle. So that, that just puts some pause in my thinking sometimes, and they're sending this to the FDA for further kind of review. Go ahead and next slide. So this is the last section, and I'm going to entitle this The Good, the Bad, and the Ugly of Telemedicine. So I know you're eating, but who in the room thinks telemedicine is a good thing? 2, 3. Who thinks it's a bad thing? 1. Who thinks it's ugly? 1. So we have like 3,000 people in the audience here, Stuart. No. So, okay. That what? They're ugly? Okay. They were good. Okay. So here's the thing. I mean, the reason there's good and bad is because of burnout from staff and physicians, and we'll get to that a little bit. So why do we actually have it? Largely because of the COVID pandemic, which triggered a sudden and dramatic change of how healthcare was provided. Rightly so. Rightly so. There's no doubt about that. But it shifted the pendulum towards a virtual treatment for several years. So currently there's a mix of face-to-face as well as virtual treatment, right? So the healthcare emergency waived restrictions for Medicare and commercial Medicare, and then the commercial payers came along with it. So it's set to expire December 31st of this year, telemedicine, okay? With the exception, there's some exceptions, rural areas or for acute stroke diagnosis in a hospital setting or mental substance abuse visits. Now, it's scheduled to expire. That doesn't mean it's going to expire. You know, things can change. So there are codes that healthcare providers are paid for called CPT codes. So CPT codes are tied to reimbursement and time spent for virtual services. Next slide. So there, and I didn't know this until I kind of looked into it, there are different types of telemedicine. So that gets into the nuances. Telehealth is a visit that would normally occur in person, but instead is conducted via telecommunications, WebEx or your phone or something like that, where you have back and forth. It obviously limits hand-on examination of patients, and as a neurologist, it's very difficult to test a person's reflexes online and test their sensation and things like that. Then you have a virtual check-in, which is a documented brief 5 to 10 minute communication, either by telephone or by video, between the patient and the provider to determine whether the patient needs to come into the office or require further services. So that is a virtual check-in, 5 to 10 minutes on the phone. I got this going on. Do you think I should come in? Or do you think I need something else? Okay, 5-10 minute thing. That's called a virtual check-in. And then the big thing is e-visits. So that has to do with patient portals. And we'll get into the patient portal thing. So a e-visit is a non-face-to-face communication that's initiated by not the healthcare provider, but by the patient. Get on the portal, leave a message, and then with their physician using patient portals, right? So physician has to use what's called medical decision making. They need to read the thing and make a medical decision. So examples are portal messages requesting a medication adjustment, worsening of a pre-existing symptom. It should not be used with complex concerns or a substitution of an office visit. So the patient portal is like, I need a refill of my medication. But some patient portal messages are a page long. I have this, and what should I do? And there's a published document from the AMA, Medical Association, from a physician at Cleveland Clinic who calculated that the average time it takes for a physician to look at a patient portal is like 2.35 seconds. 2 minutes, 35 seconds. That'd be pretty fast. But if you figure you got 40 to maybe a busy practice, 40 to 60 patient portal messages a day, that's an extra 2 hours and stuff, and that is not reimbursable. So that's driven some concern. Next slide. So the patient portal came about because of the Health Recovery Act of 2019. You had to meet what's called meaningful use, and the meaningful use had to, in order to use a EHR system, electronic medical record, and avoid penalties, providers were required or needed to have a patient portal. That was part of the deal. If not, you get penalized. So I think it's good because, the patient now can review their demographics, medication, pharmacies, visits, test results, and appointments, right? You can share records. You can contact your provider 24/7, but you got to understand what it's made for. Okay, it's not made to substitute a face-to-face office visit. The other thing is test results. Sometimes the test results go immediately to the patient portal before the healthcare provider signs off on the results. So the patient may know the results of their lab or their MRI before the healthcare provider. And so what happens sometimes, you'll get some results and the patient doesn't know the meaning of this, but it's flagged as abnormal, red letters and all that stuff, and you start to panic. Then you do the portal thing and saying, what's the next thing? Next slide. So this is the last slide I have. This is the American Medical Association, what doctors wish patients knew about using a patient portal. So this is my education back. So keep the message short, right? If it's a long message, you should come in. Only one message. So for example, if you submit a electronic message that please refill my medication, and then you also call the office and leave a message, please refill the medication. So there's two intake things that have to be sorted out, just not one. And then we get messages from the pharmacy, can we refill the medicine? So there's one thing to refill the medicine, but we have to respond to 3 messages just to get the same thing. So provider responses will probably be brief. It doesn't mean the providers are rude, but you just have a limited amount of time to answer yes or no, not expect a big, 4 or 5 paragraph response. Additional portal concerns, inbox messages at the patient portal has risen by 157% since 2020. And that's led to additional clerical and administrative costs to kind of go through all the messages. So with that, I'd like to bring my section to an end and certainly open it up to questions. I hope that this segment of looking into the future of MS was educational and informative and thought-provoking. So if it is, I think I've done my job. So I'm here to answer any questions you may have. Thank you.
Wait. So first off, let's give Dr. Thank you. He did a good job. Very good. Thank you. I like all the different terminology you used as well, all right? Person asks about optic neuritis, and does a person go blind from it, or can they remain with their vision?
So optic neuritis, there's three forms of optic neuritis. Talk about good, bad, and ugly. So the good optic neuritis is where you have inflammation of the eye nerve that's transient. You may have trouble with color perception, maybe blurred vision, maybe some transient blindness, blind spots, but it gets better. You do an MRI and it's clean as a whistle. So chances are that's not related to MS. Bad optic neuritis is that you have the same thing, but you do an MRI and you see lesions of MS, and that means that there's a risk of you having MS. But chances are, if it's MS, your vision will come back. The ugly optic neuritis is the one that's associated with the neuromyelitis optica, where you can go permanently blind with that form of optic neuritis. That's why that one particular blood test is vital.
Great, thank you.
I had never told you this, but I had stem cell replacement, and it didn't help. But the tumors, where do the tumors come in? At the injection site or throughout the body?
Yeah, they're kind of scattered. I didn't mean to scare you in any way, but that it depends. Not all stem cells are associated with tumors. Certain types of stem cells, as I mentioned. So I can't comment on your particular type of cells.
Okay. It was from the umbilical cord.
There's nothing much he could tell you about it, though, without him having done it, which he doesn't do. Right.
First of all, thank you very much, Dr. Negroski. I learned a lot, really, just like anyone else. A quick question for you. I'm interested in myelin repair research. What's the status on that, of, especially oligodendrocytes, their functionality in it? And another one is that I'm okay with that. That's all.
So that's an excellent question. That gets in myelin repair gets in to the there have been some studies using other models of myelin repair, like optic neuritis or a crush injury to the optic nerve and stuff. And so a lot of the companies are still looking into that, but nothing that's coming to the forefront. We thought that the BTK inhibitors may be helpful in terms of preventing some of the smoldering plaques and perhaps helping myelin repair. So if you get rid of, my analogy is if you have a kind of a tree or a dead branch, you prune it back, you get rid of the dead branches, and then what happens? It kind of resprouts. So that gets into perhaps myelin repair.
So going further with the smoldering MS, somebody wrote a question online. They wanted to know, how do you know how much it's smoldering or not?
Yeah, that's the big thing. I mean, that's why they have certain MRI parameters. There's an article that just came out last week looking at smoldering plaques in different layers of the cortex, if it's deeper or more superficial, and so the more to come, basically. But that's a hot topic, really.
Great, thank you.
A while back, this is like years ago, there was a young guy that had MS, and he was pretty serious, and so he wanted to get rid of this MS, and so he was, I don't know if it was trial or not, but it was Dr. Burke, I think, from Chicago, and he depleted, you would stay in the hospital or whatever, and you take all the blood out, and your whole immune system is depleted, everything is gone, so you have nothing to protect you with. I don't know if you remember that one. And then
Well, usually if you take your blood out, you die.
Well, no, they just removed all this stuff. You can help me with this, right? You remember? And 3 days later or something, they put it back. He's so fragile because he's so could get any germ or whatever and die, but they didn't. He was isolated in a place, and then
Yeah, well, there's the thing with that that gets into, I just talked about the stem cells, right? But how do you prepare the body for the stem cells to be introduced? So you can do immune depletion therapy with chemotherapy, and you have to kind of be in a bubble, so to speak, and then you reintroduce stem cells, and then they take hold and they grow, but that is a well-known treatment. It does have risk, and like I said, if you're going to go down those pathways, there should be at the accredited dated centers or clinical trial.
More of that?
Yeah,
Oh, okay.
yeah. There's several places in the United States. Yeah.
Great, thank you. So there was that study going on in the Chicago area. That was an accredited center. Okay.
So in regards to lesion MRI load, what's considered high versus low?
Yeah, so the question is, what's high lesion load? I'm going to answer it with another question, is location. So you can have a small lesion in your spinal cord and it could be devastating. You can have the same size lesion in a nook and cranium in your brain that really doesn't do that much and have no symptoms. So a lot of it depends where the lesions are. So if the lesions are in the spinal cord, that's more concerning, or in the brainstem. But the volume of lesions, the more lesions are not good. Yeah, but there's no cutoff because it's the location. That's the key. And when you just look at number of lesions, that doesn't necessarily correlate with disability. Does that make sense? Yeah.
So my question is about in like the smoldering phase. So we talked about like the biomarkers and like the TSPO and the PET signal thing and the National Football League one, the NFL. Are those like blood tests that I might get now, or would that be useful as a predictor?
Yeah, you can get blood tests. The issue is what do you get out of the blood test?
So will I get one for my next visit, in other words?
Well, I can't talk about your visit with me. I mean,
right. I'm sorry. I didn't mean that, but
here's the thing. These biomarkers are kind of meant to guide the treatment regime. So you put a patient on X drug. Do you know it's working? You don't want to just have the relapse or the MRI lesion. You want to know if the drug is working. There's some data out there that if you follow these levels, like the NFL filament level, over time, and it keeps on going up and up, maybe the drug is not the right drug for you. But an isolated level doesn't tell you much. It's the trend, right? So if it goes down, maybe it's beneficial. So the markers are not cheap either. So yeah.
And then I just did one more. I had a lot more, but I'll only do one. So the BTK inhibitors, I mean, it sounds like they're kind of sort of experimental or still in, I mean, maybe they're used, but not sure if they really work, or is that in addition to your regular medication?
No, the BTK inhibitors, the first one was up for FDA approval, but then when they broke the code, it didn't hit their first primary endpoint. So in drug studies, there's many endpoints, maybe 10, 6 endpoints, but you have to hit the primary one. If the primary one isn't hit, that's a failure, but all the other ones, maybe they hit all the other ones. But the primary has to be hit, and it wasn't. The other drugs are still in clinical trials, so they're going forward with that. Yeah.
Great, thank you. By the way, Somebody told me that Rudolph was known as a very famous deer, and they named Tyruko after the antelope.
Ah.
I didn't.
I have an annual neuro-ophthalmologist appointment tomorrow, and I'm fascinated with biomarkers. And I was wondering if this whole red-green color vision thing and possibly even our changing in contrast can be considered biomarkers and indicators of PIRA or not. And does anybody look at it that closely?
Yeah, I don't know. I can't answer that, but yeah. Yeah, the neuro-ophthalmologist. Yeah.
Yeah, I was wondering, all those things you're saying is so mind-boggling that, trying to absorb all this, maybe I'm just not smart enough. But I think that is AI used in terms of classifying in every level of medicine, in terms of live testing, you do use AI to really test drugs.
Yeah,
and so forth.
I'm sure they're looking into that. Yeah.
Yes, I think so, because they're very less expensive and more effective, I would say. Thank you very much.
My question has to do with inflammation. Now, inflammation is part of this MS journey, correct?
Yes.
So when we're having inflammatory issues, how do we know if it's an MS flare-up or if it's another autoimmune issue? I mean, are they sort of just kind of holding hands and we can't differentiate, or?
So inflammation in the human body, I think, is a bad thing. I mean, you can get inflammation from stress, emotional stress, inflammation from diet, inflammation from surgical procedures. I mean, that's the body's response, how you respond to things. Yeah, I think so.
You repeat that for?
Are some people more prone to inflammation than others? Yeah, just like anything, it's a continuum. Everything's a bell-shaped curve. So all the population isn't in the 50th percentile, so.
Okay, thank you. Next from online, can a person have MS in both legs?
Yes.
Thank you. Next, any information about drug trials for new therapies should be helpful to know about?
Yeah, I think the National MS Society, as well as the NIH websites for clinical trials there's a lot of clinical trials looking at symptomatic therapies, treatment therapies, biomarkers, and all that stuff. So that's online for the.
Okay, next one. What is a central vein sign on MRI metrics?
So it's a very powerful MRI, and if you look at these immune cells circulate, right? The immune cells circulate in the arteries and they circulate in the veins, just like any blood flow. MS tends to be a perivenual. MS lesions are around veins. So if you ever eat a steak and then you cut it, you'll see a little round circle. That's an artery. If you see a little squished ovoid thing, that's a vein. So the ovoid lesions in MS are typically perivenual because they're ovoid on the MRI. They're not like little punched out things. So there's a suggestion that if you have a perivenular, if it's around the veins, that's more consistent with MS. Strokes, for the most part, affect arteries, not veins. So that's where that comes from. But in order to kind of differentiate, you really need a very good MRI machine.
What if NFL biomarker shows a good number consistently, yet the same patient's lesion load is heavy and seemingly smoldering, with relapse increasing in frequency and severity? How is it possible for one biomarker to show much better results from another and not reflect what the patient is actually experiencing?
So two answers to that question, and it was a really good question. One is that you treat the patient, you don't treat test results, number one. Number two, one or two biomarkers, there's 20-some different biomarkers, and sometimes some companies are looking into the combination of all the biomarkers to see which one or what combination actually stands out. So I think in this stage of the game, maybe you just look at how the patient's doing and don't put all your eggs in one basket, so to speak, in terms of making treatment decisions on one single biomarker, two biomarkers.
Thank you. You talked about aging versus MS, and you talked about both showing signs of brain loss, I guess is what you were talking about. What are the symptoms of that in both aging and MS? Are they similar, dissimilar, and what might they be?
So the question is, can you tell the difference between a normal aging brain and an MS brain as it ages, other than the rate of loss of tissue? The thing is that if you have MS lesions to begin with, you have already caused some loss of brain tissue, but other parts of your brain can take over. It's called neurological reserve. If, as the brain ages, it's like putting gas in the tank. If you have MS, maybe you have 3/4 of a tank instead of a full tank because of the pre-existing lesions. So if the constant burn rate, you'll run out of petrol sooner if you have MS, not because you have more MS lesions, maybe your symptoms will be worse. So it's very difficult to tell the difference. It really is. So that's why a lot of these other markers and a lot of MRI metrics may help us explain, the difference between MS deterioration and normal aging deterioration. But that's a key question. It really is.
Thank you.
You talked about earlier the different medicines according to patients, like what they want to do. Is there any alternative to steroids, or is that
so? In terms of the steroids are typically used for acute flare-ups. Steroids are really good anti-inflammatory medications. So when you have an acute flare-up, you'll have focal inflammation. So you give the patient the steroids to relieve some of the symptoms. But it's not used as a long-term treatment to change the disease course. Does that answer your question? Okay.
All right. This person writes, your opinions on DMTs and aging. Sorry. I've had relapse remitting over 50 years. I'm now 71. What should I do?
So
basically they want to know if they should be doing a DMT with relapse remitting for a person that's over 50 years old. What is your viewpoint on people being over 50 and doing?
Yeah. So I do treat older patients with disease-modifying therapy if they have active MS. I kind of look at, there's two things. There's the chronological age, and then there's biological age. And, just because a person is certain age, that doesn't mean that, their immune system all of a sudden shuts down. So I've seen patients on both ends of the spectrum. So if a patient still has some evidence of disease activity, I'll tend to treat them. What, from a practical matter, is insurance coverage. And patients that are Medicare of age 65 and above, sometimes it's much more difficult to get copay assistance through foundations. A lot of the foundation money is kind of drying up, and as a result, financially, it's very difficult to afford drugs. So the issue becomes, when should you stop the medication? And there are some limited studies out there looking at that issue. And one study from Colorado suggested that one approach wasn't inferior to another approach about stopping or continuing a drug. But there's some caveats with the study. And some patients did have MRI activity or relapses after they stopped the drug, but it wasn't statistically significant.
Hi. Going back to brain atrophy and aging and that, my question is about, if you have MS and you have traumatic brain injuries, does that alter your MS or affect it, or, you know?
Yeah, to my knowledge, I don't think there's a relationship, but it may increase your risk of, increasing disability if you have pre-existing, as the brain ages, you need all the brain cells you need, And if with traumatic brain injury, you've had some damage, and then you put MS on top of that, that's probably not a good thing. But I don't think they're directly related to disease progression per se. Yeah.
All right. Another one from online. Person wrote, you spoke about the biosimilar for multiple sclerosis. When will it be made available?
The biosimilar is, it's been FDA approved, but I think in a few months. I could be wrong.
Okay. I'll research that one.
Hi, Dr. Negroski.
Hi.
Hi. I have a question on spasticity.
Yep.
Are there any new treatments?
So the spasticity in MS is a big thing. The issue becomes how best to treat it. And there's the old drugs, for anti-spasm drugs, but this magnetic stimulation kind of looks a little bit promising. And then the cannabinoids, THC and CBD and things like that, may help spasticity. That depends on the state that you live in, if it could be provided for medical purposes. So, as you know, living in Florida, you have to have a medical card to do that.
Okay, question here.
Patient portals have become very, very, I don't know what the word is, prominent in recent years. If they're so much more difficult for doctors, why are we doing them?
Because it's required to have a patient portal by the Healthcare Act. It's one of the meaningful uses that the government has required us to do. So if you have a patient portal.
But 10 years ago, they didn't. So when was this requirement effective?
The Healthcare Act, so-called Obamacare, was, I think, in 2009, but that keeps on morphing. These meaningful uses, every few years, they tell the healthcare providers what is kind of required that may not have been required in the past. So it's a kind of a fluctuating thing. And plus, years ago, people didn't do patient portals because they didn't hardly do telemedicine, right? So,
given IV Ciamedrol high dose for 3 days, how long do anti-inflammatory effects of this treatment generally last?
So the thing is that we kind of think that it shortens the duration of the MS symptoms. But if you're going to get better, you would probably get better eventually, but it will shorten the duration. So the question is how much it shortens it. Each person is different. Depends on the degree of inflammation, where it's located, what kind of symptoms, things like that. But it's variable. It really is. It's patient specific, in my opinion.
Well, thank you very much for the lecture, and this is pretty overwhelming with all the information, and I really appreciate you doing this. But you mentioned something about the antihistamine medicines,
Yeah.
that the Clenstein, I think it's called, and that it helps with the myelin regeneration, I think you said. Can you elaborate a little bit more on
So
that?
myelin water content. So that's an experimental MRI that kind of showed that it had some kind of effect in the brain, water content and myelin. Does that mean it's helpful, or does that mean it's going to make a difference in everyday life? The answer is no one knows. But that's proof of maybe further research in that. So I'm not recommending that people go out and, take that or the diabetic medication. But those were kind of that on top of that slide is kind of interesting concepts as opposed to FDA-approved concepts.
All right, Doc, you're done. Done with the grilling, right?
Thank you.
Nice seeing you again. Doesn't he look younger? My God, I haven't seen him since before COVID, and he looks like he got to be like 25 again. In fact, when I saw him come in the door, I thought it was a college student coming here to learn.
Thank you.
Is that what it is?
Yeah.
Okay. He's got to run around again, right? Okay. Well, I want to thank you all for coming here today. Again, we can't do these programs without you, and we do these programs for you all. So I'm glad that you were able to come down here and make it all happen. So drive carefully going home, and don't let the bed bugs bite. Have a good day.